the surgery. So this is very important. On table intracholangiogram. Please don't forget, it is getting slowly decreased because of the MRCP pictures. Okay, this is very important thing. You should not forget. So now, the Mersey syndrome, please don't forget. These are some other complications we will be facing during surgery. So this is another complication. Sometimes what happens, the stone from the gallbladder will enter the duodenum because of a fistula. Can you see this is stone? Directly from the gallbladder, it has entered into the duodenum. That is known as Boveret syndrome. So this is due to cholecysto. It is not entering through bile duct. It is from gallbladder to duodenum. Cholecystoduodenal fistula. This cholecystoduodenal fistula has formed a fistula here, and the stone has come into the duodenum and causing obstruction. But mostly it will not cause obstruction in the duodenum. It will come out and it will cause obstruction in the bowel, in the terminal ileum. That is known as gallstone ileus. This is a PG topic. PG aspirants question. This is a PG aspirants question. So gallstone ileus is nothing but due to cholecystoduodenal fistula. The stone enters the duodenum and comes down and obstructs the terminal ileum that is characterized by a Rigler's triad. Rigler's triad characterized by fistula, pneumobilia, presence of air in the biliary system, pneumobilia, and number 3, obstruction of the bowel. So this is known as a Rigler's triad, a feature of gallstone ileus. So when we encounter these type of cases like a cholecystoduodenal fistula, never hesitate to open. We will always convert it into open surgery. So the only concern we will be getting apart from the bile duct injury is concern for open cholecystectomy. Surgeons should never think conversion of open as a impotence. You should not think it is an impotence. It is masculine. I will tell you, it is a masculine decision. So from conversion from laparoscopic to open, many surgeons, I still see many surgeons I'm seeing, no, they always have a hesitation to convert a laparoscopic to open. They think if I convert laparoscopic to open, the patients will think bad, the anesthetist will think bad. Whoever thinks bad, why should you worry about it? Because it's the life of the patient. You should not take risk. Never do damage to the patient, even if you're not going to do good for the patient. So if there is a problem during surgery, never hesitate to convert laparoscope to open. I'm telling you, so far I have done 100 cases, I have more than 100 cases, but I have converted more than 10% is my open rate. I will always be never hesitant to do open. If I do open, I will be very much clear with anatomy and I will be ready to tackle any injury, bile duct injury or any stone, impacted stone, anything I can manage if I convert it to open. So converting to open is not an importance. It is the most manly decision taken by the surgeons. Please remember this. So never ever think that I will always do with laparoscopy only. There are so many surgeons who got into trouble only with this ego. I will do it in laparoscopy only. I will never convert to open. If somebody is telling, I'm telling you, even to the patients are the same thing I'll tell. If somebody is telling I will do 100% with lap, I will never convert to open. Please don't go to them. You are in trouble. If somebody is telling if there is a problem, I will open. If there is necessary, I will do open and do the cholecystectomy. Means you go to that surgeon. Is definitely going to not cause damage for you. Is going to save your life. Okay, this is very important thing. So laparoscopy converted to open. There are many indications. That is important indication is Kellogg's triangle. Anatomy not clear. This is the most important thing. If the Kellogg's triangle anatomy is not clear, you should always never hesitate to go for open. You should never hesitate to go for open. And this type of laparoscope to open happens usually when we do surgery for acute cholecystitis. More happens when there is a chances of acute cholecystitis. It happens when there is a chance of acute cholecystitis. There is more chances of converting it to open, but nothing wrong. You can always do by a open cholecystectomy. If there is dense adhesion or a mass, Kellogg's triangle not seen. So I told you intracholangiogram, the latest role is not there. Only when you suspect bile duct injury, you do a intracholangiogram. Otherwise, we are not doing intracholangiogram because we always have MRCP before going into the surgery. So now coming to the topic of complications of cholecystectomy. This is actually essential topic for PG aspirants. I'm going to tell you some scenarios which are always asked as a MCQ for your exams. This topic is purely for PG aspirants. Scenarios in laparoscopic cholecystectomy. All these are clinical based questions in AIIMS and other institute exams. So I'll tell you each and every scenario now one by one. So first scenario, how many ports you make? How many ports you are going to make? This is a very basic question. As final year students as well as PG aspirants, you should know this. How many ports should I make? So the first port I make is a camera port in the umbilical area. This is 10 mm port I will put in the umbilical area for doing the surgery. Put an umbilical port 10 mm. So the other ports are, 3 ports are made. One in the epigastric region, 5 mm port for right hand of me operating. For right hand operation, I will put a port at epigastric region. Mid clavicular line or near the gallbladder, you find out and you put a 5 mm port for my left hand operation. So I have to do 2 hands. I'm going to remove the gallbladder. So I have to put a 5 mm port at epigastric region, another 5 mm port in the mid clavicular line, and another 5 mm port is going to be used by the second assistant. The first assistant is going to be using the camera, is going to hold the camera. So the second assistant is going to stand on the right side of the patient, and he is the actual hero of this case. Who is the actual hero of the case? This case is not done by me, not done by the camera person. The entire surgery depends on this person, second assistant. He is the hero for this patient, for the surgery. Please remember, he is the hero. Why? Because he is the one who is going to show you the Kellogg's triangle, opening the Kellogg's triangle, everything by pushing the gallbladder fundus, holding the fundus. He is going to push it towards the right axilla. If you have a poor second assistant, your entire surgery will be collapsed and your anatomy of Kellogg's will not be opening up and you will damage more structure. So please remember, I will always take a skilled assistant for this procedure. Second assistant is more important than a camera person. He has to stand like a statue, holding the gallbladder towards the right axilla. If he should not be too much forcing, at the same time, he should not be too much loose. He should be holding in a perfect way. He has to stand just like that for half an hour to 1 hour, even sometimes 2 hours. You have to hold this, and therefore he is the most important person in the surgery. Please remember. So that is the right axilla is for, sorry, the right lateral port is for retraction. Right lateral port for retraction. Please don't forget this point. So there are 4 ports, 2 operative ports. These 2 ports are held by me, surgeon, and this is a second assistant going to push the liver towards the right axilla, holding the fundus, and the first assistant is going to hold the camera. So this is how many ports? 4 ports are used. First question. Second question. So you are a general surgeon. You are a general surgeon not having much orientation towards the liver resection. Question is very clear. General surgeon, you are operating, you are putting 4 ports. The first port I am putting now, as a general, if I am a general surgeon, I am putting the first port, 10 mm port I am putting. And on seeing the gallbladder, I am seeing there is an issue. The gallbladder looks like there is a growth there. Looks like a growth. Looks like a cancer. So the gallbladder is having some, at the level of fundus, there is something like a cancer. So this is an AIIMS question. As a general surgeon, you are putting a 10 mm camera port at the fundus of the gallbladder. You are seeing a cancer-like thing. What will you do? I will give you the choices. You just answer it. So because usually you can answer it without choices. When you see the choice, you will get confused. So take biopsy. Choice number A, take biopsy. Do laparoscopic cholecystectomy. Do laparoscopic cholecystectomy. Abandon the procedure and refer to GI surgeon or hepatobiliary surgeon. 4, there will be something else. So which is the correct answer here? So as a general surgeon who is less experienced with the liver surgeries, abandon the procedure and refer to GI surgeon is the correct answer for this question. Abandon the procedure, take the port out and just safely refer the patient to a hepatobiliary surgeon who can do a liver resection for a gallbladder surgery. So, and before you refer the patient to GI surgeon, he will take care of the patient further. He will evaluate for the cancer, everything. Because many times why this problem happens is, we will be having some local scan center nearby. There will be some new radiologists. They may be giving ultrasound shows multiple gallstones. This will be the report. So you'll be thinking multiple gallstone. There is nothing much to worry. Therefore, you will be going for a laparoscopic cholecystectomy. And as you put the port, then only you see there is a cancer which the radiologist would have missed. This commonly happens. As you put the port, there will be a cancer the radiologist would have missed. So I'll show you one such case. I got from one of my friend from Kalakuruchi. He operated one case. While operating, what happened is, he thought it is a it's like a what do you say? He thought it is a gallstone disease and he opened it, but finally what happened is it turned out to be a malignancy. Therefore, what he did is he immediately removed the ports and he referred the patient to me. I'll show you that patient. Actually, that's an interesting thing. You should never try to proceed further. As a general surgeons, they should be never try to proceed the patient. So you can see this case. This is a case of see a gallbladder. As you can see the ports. This is a port, 2 ports he has made. One port umbilical and another port. Just touch and see. So he put 2 ports. At that time, he noted there is a cancer in this place. So he abandoned the procedure. So the patient was referred after 2-3 days to our hospital. We opened the patient and we did an extended cholecystectomy, including part of liver. This is a extended cholecystectomy also done, and inside there was a early cancer. So this is what we must do for a patient suspected to have cancer. You should refer to a GI surgeon. So number 3, the same question. Number 3, the same scenario, but you are already a hepatobiliary pancreatic surgeon experienced with the liver resection. Experienced with the liver resection, you are already a hepatobiliary pancreatic surgeon who can do a liver resection. What will you do? So as a hepatobiliary surgeon, I will first step what I will do. Next step what I will do. I will not abandon the procedure. I will convert from laparoscopic to open. Please remember, convert laparoscopic to open technique. So this is what the next step. This is also an MCQ. So I'm telling you, these are MCQs which are asked in the exam. So if there is a malignancy, if you're a hepatobiliary experienced surgeon, convert laparoscopic to open then and there itself. If you have some gastrointestinal surgeons available nearby, you can call the surgeons for a open procedure. We can go for a on table. We can go for a radical cholecystectomy can be done. Radical cholecystectomy can be done on the same sitting. This is another question, important question for the exam. So this is a clinical scenario 3. Okay. So clinical scenario question number 4. So all these questions are asked in AIIMS and other institute exams. You should never have a doubt at all. So next question I'm going to tell you, we have done a surgery for a laparoscopic cholecystectomy successfully for the patient. Now the patient on second post-op day is coming to you with the complaints of pain in the right hypochondrium. He is having fever. Pulse rate is high. Pulse rate is high. So it's on a second post-op day or a third post-op day or a first post-op day. Also patient is having pain, fever, at the pain at the right hypochondrium, fever. What should I do next? What should I do next? This is a question. What will you do next? So this is a 100 times asked repeat MCQ for your exams, and you must immediately send the patient for an ultrasound to look for bilioma. This is the next step you must do. So ultrasound is done next for the patient. You should look for ultrasound to look for a bilioma. Please don't forget, I will immediately do an ultrasound to look for a bilioma. This problem we never face in many practice because we always keep a drain after laparoscopic cholecystectomy because we don't have many intervention radiology facility in our place. So always we do a drain for 1 or 2 days. Especially if we had a tough cholecystectomy, we always keep a drain for 1 or 2 days. And if there is a leak, we will get the leak in this bag itself. I recently also posted one of the video of one of the patient who had a cholecystectomy followed by a leak. So we will get a leak in the bile duct. So this is what we do next. So next, what will you do if there is an injury is we have to do an ultrasound because in Western countries, they don't keep a drain. So you have to look for an ultrasound. That ultrasound shows a collection. What will you do next? This is the problem in our place. We don't have intervention radiologists many times to put a percutaneous drainage. You have to put a percutaneous drainage. If already there is a drain, no need to worry. But if there is no drain, I have to put a pigtail catheter. The drain will be looking like this. I'll be putting a pigtail catheter into this place. I will be taking this and I will go and put this catheter in this area. So what happens? Automatically the bile will come out through the drain. That will come out through the drain and the patient will have decreasing pain, decreasing fever and pulse rate because this is purely due to biliary peritonitis. This is a case of biliary peritonitis. The patient was having so much of symptoms. So biliary peritonitis, that is the reason for this. We have to put a drain and we have to wait. So what will you do then? Percutaneous drainage is done. So this is a protocol. After doing a percutaneous drainage, what will you do? So I will wait for 2 weeks. I will wait for 2 weeks. In 2 weeks, 90% of the leaks will settle. 90% of the leaks will settle. The leak stops. 90% of the leak stops in 2 weeks. So if the leak is not stopping at 2 weeks, if it stops, no need to worry. You can go for MRCP at 8 weeks. You can do a MRCP at 8 weeks. If leak is not stopping, leak not stops. What should I do? If leak not stops, then I should do a gold standard investigation for bile duct injury. This is again a NEET PG question. Gold standard investigation. Gold standard investigation for bile duct injury is ERCP. Please don't forget the gold standard injury is ERCP. In ERCP, I will have a classification very commonly asked MCQ. These are all full of PG related topics. Strasbourg classification. ERCP shows a classification known as Strasbourg classification. When will you do ERCP? Only after 2 weeks. We don't do it immediately. At 2 weeks, we'll do a ERCP that will show you a classification known as Strasbourg classification. The most common cause of bile duct injury is this. Cystic duct, I have put a clip. No, this clip will fall down and the bile will leak. This is the most common injury. Cystic duct blowout. This is known as cystic duct blowout. That is type A Strasbourg. Type A Strasbourg is leak from the cystic duct, and cystic duct blowout has happened. Nothing to worry. It will resolve by itself. It resolves usually by itself. It will usually resolve in 2 weeks or 4 weeks. Nothing to worry about it. So type B injury is, type B and C are injuries of aberrant duct. I showed you the images of anomalies. No, in this anomaly you see, this is a anomalous duct. This is cystic duct is normal. See the picture of B and C has a anomalous duct. This is known as aberrant right posterior sectoral duct. I told you, the posterior sectoral duct can get injured. That complication is this. Aberrant right posterior sectoral duct is being clipped is known as B. Clipped. It is not leaking. Therefore, there is no leak in B. It is cut is known as C. C for cut. Therefore, there is a leak. So aberrant right posterior duct is cut and that is leaking is C. D is a lateral bile duct injury. This is an injury. D is lateral bile duct injury. E is very worst injury. There is no excuse if you do this type of injury because they have cut the CBD completely. CBD circumferential injury. This is what I told you. Sometimes what happens when you pull it, CBD appears like a cystic duct and we put a clip for the CBD. This is what happens. So this is type E, circumferential injury. This is Strasbourg classification of ERCP. Please don't forget this classification is very important for PG entrance exams. PGMA exam, this is most important classification. In this classification, the question is which one have no leak is B has no leak. A has leak, C has leak, D has leak, E has leak. All A, C, D, E patients presents as bilioma. So we don't know what leak it is until you do an ERCP. Initially, there is a bile collection, we have put a drain. But how to know where is the injury? We have to do ERCP after 2 weeks. And ERCP is done now. We have found out the leak. What will I do now? Even now, I won't do anything. I will, if at all, I may do a ERCP, sphincterotomy, and stenting for few cases. ERCP, sphincterotomy, and stenting can be done. For which cases? For A injury, I will do like that. It is useful. If I do for A, it is useful. If I do it for D, it is useful. You can see, I can do a ERCP and sphincterotomy, and I can put a stent like this. Plastic stent inside the bile duct. This is A, it is useful. What is the use of I am putting for a C? No use. In C, there is no use. Anyhow, it is going to leak only. So no use for C. But for D, I can put a thing like this so that it will form a channel to drain the bile like this. So D, it is useful. So E, you cannot put a ERCP stent at all because it is cut. I cannot pass the stent into this place. It is impossible. So A and D, ERCP, sphincterotomy, and stenting can be done. Usually the medical gastroenterologists, they do this. Medical gastroenterologists, when they do ERCP, they find out what type of injury. If it is A and D, they will put the stent immediately. They will put the stent during the procedure itself. So E, they will tell, sir, that I cannot pass the stent. It is very full cut injury. We cannot do anything. Like that they will tell. So anything after 8 weeks, after this 8 weeks, what happens? We have to wait. The leak will be coming, and slowly after 8 weeks, it will stop. How does it stop? Does it heal the injury? No. The injuries all heal with the formation of strictures. Now the real problem starts. So the patient, that is why I am telling laparoscopic cholecystectomy, be careful, be careful. Why we are telling again and again? Because the injuries are very, very worst nightmare for the surgeons. I have seen surgeons who could not sleep for months together because the patients will be coming to you every day, every week. They will be coming to you with the various complaints. They will develop cholangitis. They will have bile leak. Continuously, there will be a nightmare for the surgeon. So please remember, at 8 weeks, they will develop a stricture, and that they will not only come with stricture, they will come to you with a clinical picture of obstructive jaundice. Now it is a time to know where is the stricture, what is the problem, etc. We have to go for a MRCP. Investigation of choice for stricture is MRCP. It will be done only after 8 weeks. It will be done only after 8 weeks. In MRCP, there is a classification of strictures. I hope you know that I'm not going into that. That is bismuth classification of strictures. So that will tell you where is the stricture, what type of stricture, everything is there. That is beyond the scope of this chapter. But bismuth classification, I'll tell you, if the stricture is more than 2 centimeters from the hilum, it is type 1. If the stricture is more than 2 centimeters from the hilum, it is like this now. For example, there are many classifications like this. Bismuth goes on up to 5. So bismuth type 1, there is a stricture like this at more than 2 centimeters. So what am I going to do now? Now you must be very careful. The person who is going to touch this patient now has to take full responsibility and serious thing. And the hepatobiliary surgeon will be called now. He will be going and dissecting the bile duct, and he will be bringing a jejunum and anastomosing with the bile duct like this. It is known as hepatico-jejunostomy, because we have to open the bile duct above the stricture and we have to do hepatico-jejunostomy. This is the problem. We should have to go for a major surgery now. We have to open the abdomen, we have to bring a jejunum, and we have to anastomose with the bile duct stricture. So this is hepatico-jejunostomy has to be done. I have seen a few patients who developed a stricture like this, They didn't come for hospital. They had obstructive jaundice for months together, like 6 months, 1 year also. The surgeon has not properly referred the patient, and the patient developed a secondary biliary cirrhosis. Just 35 years woman, 35 years lady. She has not been properly evaluated for the stricture. She had jaundice and she came to the hospital with a secondary biliary cirrhosis. When I'm doing MCH during my postgraduate day, the patient came with a secondary biliary cirrhosis, and the only treatment of choice for this case is what? Liver transplant. Please remember, a gallbladder surgery patient who came for a simple gallbladder operation, removal of gallstone, 6 mm, 7 mm stone, the patient has come for operation, and the patient has landed up in bile duct injury, stricture, finally with a biliary cirrhosis, and finally went for liver transplant. So therefore, the gross mistake here is not injuring the bile duct. Yes, bile duct injury is possible. 0.5 to 1% chances are there in a laparoscopic cholecystectomy. That cannot be, we cannot stop doing surgeries because of the problem of bile duct injury. But the mistake from the surgeon side is you should recognize it early, identify the injury, refer the patient to the correct surgeon, and repair the injury. That is the most important thing. There is no excuse if we leave the patient to go for a secondary biliary cirrhosis and patient finally landing up in a liver transplant, especially a 35 years lady. That lady landed up in a liver transplant. We saw one such patient and I'm doing MCH. That's a very worst treatment of the surgeon. So this and all should never happen. So you should identify that if you're doing a laparoscopic cholecystectomy, you should know everything about laparoscopic cholecystectomy. You should know A to Z, what complication can happen, what to do if there is a complication, whom to call, what to do if there is a complication, how to solve the complication. Everything you should know before doing a laparoscopic cholecystectomy, because you are dealing with the life of the patient. The patient will be lifelong handicapped. So the last scenario I'm going to discuss in the last discussion is on